Mary's story is a very common presentation to Australian paediatricians. These are data that are old data now from Peter Houston's group down at Barwon, where he got all of the paediatricians in the Barwon region, which is a self-contained region about an hour from Melbourne, to document the diagnoses of the children that were referred to them over a period of a year. And you can see that well over half of those had to do with conditions that were not the traditional fare of paediatricians. These are Harriet Hiscock's data from the Australian Paediatric Review Network. The top 10 diagnoses of new patients referred to paediatricians around the country were to do with developmental and behavioural and psychosocial problems. And this was foreshadowed by Bob Haggerty, who passed away earlier this year. In 1975, he talked about the new morbidity, a group of childhood difficulties that we have termed the new morbidity is now gaining attention. Many of these difficulties lie beyond the boundaries of traditional medical care. Handling such problems will be important to the future of paediatric practice. Most Australian paediatricians would regard Mary as a typical referral and would feel that they have the training and skills to assess the issues and formulate a management plan. But by the time they get to a paediatrician, the problems are often very entrenched, and we've missed many opportunities for prevention and early intervention along the way. So contemporary paediatric morbidity often has some biological vulnerability, but environmental stresses, as you've heard in Mary's history, play a very, very important role. The late Clyde Hertzman used to talk about the biological embedding of environmental events, because after a while that environmental stress begins to change the genetic material. It's often intergenerational. There's a very strong association with disadvantage, and you heard that in Mary's story today. They've been described in the literature as being wicked problems because of the complex etiological pathways, and there's no easy fixes. We need multidisciplinary approaches, and they're beyond the expertise of any one profession. So in medical school, we learn to develop the language and form relationships with radiologists and biochemists and pathologists. The new morbidity means we have to develop relationships and speak the language of psychologists and social workers and speech pathologists. Interventions, sorry, just backtrack a little. So these are some of the challenges. First of all, professional training, for example, teachers, and I'll talk about that in a moment. A fragmented service system that means these children cannot get timely assessment nor timely intervention. And you heard Mary's story of long waits for speech pathology assessment and then a long wait for treatment. There are problems of access and equity. These are children and families that experience what we call double jeopardy. These are children who would benefit the most from going to high quality childcare, are the least likely to go, who would benefit the most from going to kindergarten and tend not to go, who would benefit the most from going to good schools with resources, often go to schools in disadvantaged areas where those facilities aren't available. Their families who would benefit the most from psychosocial support from an early age are the least likely to get it. There's a challenge of siloed government policies. There's vertical and horizontal fragmentation, competition between Commonwealth and state and local governments, and horizontal fragmentation between different departments at each of these levels of government, and indeed within the one department there's no single address for children. Interventions tend to be very narrowly based, and the fee-for-service remuneration makes it problematic for paediatricians. I work in a hospital setting. I guess I'm fortunate, I'm on a salary. For every hour I spend in my clinic, there's at least another half an hour, and often an equivalent amount of time, often an hour, back in my office, calling schools, looking at questionnaires, trying to find out where the local speech pathologist is, and so on. This is a study that Nick O'Keefe and Michael McDowell published in the Australian Paediatric Journal some time ago, where he surveyed teachers in Queensland and basically found that very few of them had the confidence and the skills to understand many of the conditions that comprise the new morbidity. And furthermore, a tiny minority ever made contact with a paediatrician. And I wrote a subsequent editorial in the same journal called The New Morbidity in Education, arguing that in paediatrics, we've come to terms with a new morbidity many years ago. So it's a compulsory part of paediatric training to become a consultant. Teachers, for the most part, don't learn anything about the sort of conditions that they're going to see in the classroom every single day. We have a fragmented service system. Different shapes, different colours, different sizes. So every community in the country, except the most remote, does have a service system there. But it's not always accessible. There are wrong doors everywhere. You need a tertiary degree simply to negotiate your way around the service system. And we're dealing with some of the most vulnerable families that we know. This is a complex slide because it's actually a child's journey in an area not far from Melbourne, trying to negotiate the health and education and welfare systems, new referrals, waiting lists, barriers wherever you looked. So it shouldn't be beyond our realm of possibility to design a virtual one-stop shop so that everywhere a child and family make contact with the service system, there are no wrong doors. If you come to the right place. If I can't help you, I'll pass you on to somebody within the system who can help you, and I'll take responsibility for making sure you keep the referral. We have almost total separation of primary and secondary and tertiary services. Specialist services are usually located somewhere else with transport barriers, usually on the other side of town. Children and families have to go where the services are rather than the other way around. They have to fulfill very narrow eligibility requirements, so they're often turned away from these services. There are long waiting lists. Some children don't get seen at all because parents lose patience. And information flow is one way. Referrals are to the specialist, and we get a letter back if we're lucky. We should be moving towards a much more integrated service where specialist services are co-located with other services, or certainly have outreach to those services, where referral arrangements are simplified, where eligibility is much more flexible, and information flow goes two ways, so that the tertiary services should be spending some of their time building capacity in secondary and primary services, and secondary consultants need to spend some time building capacity in primary services. As Alan Hayes and Matthew Gray said in their publication in 2008, complex social issues cannot be dealt with merely by interventions with children, or by strengthening families, or by building community capacity. Policy needs an integrated focus on all three elements: children, families, and communities. And yet we see our attempts at trying to make a difference still very, very narrowly focused on either the child or the family or the community. This is some work that our centre did in Doveton, which is a disadvantaged area, about an hour's drive from our hospital. Look how many services and programs there are in Doveton. The last thing that Doveton needs is a new program or a new service. They need glue to glue together what's existing. Governments do not like to fund glue because it's invisible. There are no announcements, there's no photo opportunities, there's no plaques on the side of buildings. So that's a challenge for those of us trying to present evidence to policymakers. They like announcements, and they like to announce a new program or a new service. There are problems of access and equity. This is a slide of the mismatch between children who need speech pathology and where the speech pathologists are. So red and yellow are areas of disadvantage. Blue is areas of advantage where kids are doing fine in speech and language. You can see that in those areas where there are disadvantaged children who need speech and language services, there are virtually no speech pathologists and virtually no public speech pathologists. So this really speaks not just to a social gradient, because if you can afford it, you can get in to see a private speech pathologist fairly quickly, but the actual absence of the very professionals that we need to make a difference to our children. So I would argue the healthcare system is in need of renovation. It's currently geared to acute conditions. We need to transform it to deal with chronic conditions. It's currently hospital-centred. We need to move to a system that's embedded in communities. It's doctor-dependent. We need to start moving towards teams. We believe in episodic care. We need to start moving to continuous care. We need to move from disjointed care, I can't see that now, from disjointed care to continuous care. From disjointed care to integrated care, from reactive care to preventive care. And prevention is the hardest sell of all for the reasons that I mentioned before. You can't see it, you can't touch it, you can't be introduced to people who can argue about prevention. We need to move from patient as a recipient to patient as a partner, families as a partner, essential to us making a difference. We need to move from infrequent self-care to self-care that is facilitated by us, where carers are undervalued to a situation where carers are supported as partners, and from individual care to population and population prevention of care. This is Sven Silbern's slide. If we want all children to have that ideal developmental trajectory, we want every single child to fulfill his or her potential. We know that if we did nothing, lots of children would fall away because of biological and especially environmental risk. It's not as if we don't do anything. There have been long attempts over many decades, over generations, for federal government, state government, philanthropic, faith-based groups to intervene and make a difference. But current practice brings us to that red line. We know enough now from the research, from evaluated trials of interventions, to lift all children from that red line to the green line. We know enough about Mary's situation that she should never have got to where she got to as an adolescent. We know how to intervene, and that's the opportunity we have as a country, as a nation. There's no shortage of research that tells us how to build that fence at the top of the cliff. What we're missing is political will and a social strategy. Thank you.